Okay, let's unpack this. We're diving deep into a topic that is, well, incredibly common, potentially trip-ruining, and, frankly, just unpleasant. Traveler's diarrhea.
It really is, isn't it? Affecting a huge number of people who travel to certain parts of the world. Something like 50% of travelers to high-risk destinations might experience it.
Wow, 50%.
Yeah, so it's absolutely something you want to be truly informed about.
Absolutely. And our mission in this deep dive is to go through the sources you've shared with us, articles, research papers, even video scripts, to really understand, what traveler's diarrhea is, why it's such a frequent, unwelcome travel companion, precisely how you can catch it, and maybe most importantly, how to try and avoid it.
And we'll also look at some cutting-edge insights, drawing specific findings from recent research conducted in places like Nepal to understand what happens when treatments face new, really significant challenges.
Right. So think of this as your shortcut to being genuinely prepared and informed about this very common travel ill. All right. So where do we start? Let's get the basics down. What is traveler's diarrhea, fundamentally?
At its core, it's a digestive tract disorder. But the reason it's so prevalent, well, it's its transmission route. It's the most common illness travelers face, especially in resource-limited areas, which, covers many developing countries globally.
And that 50% figure for high-risk places is really quite staggering, isn't it?
It is. It really highlights the scale.
And the core issue is how you get it. It's primarily caused by eating food or drinking water that's been contaminated by feces.
Right. This is the classic fecal-oral route. It sounds simple, maybe a bit unpleasant to think about, but the sources make it clear how easily this happens in certain environments.
Exactly. Contaminated water is a major culprit, obviously, but errors in how food is prepared, handled, and stored are also absolutely key sources.
Yeah, those are huge factors. And it's not just something that strikes mid-trip. It can also develop after you've returned home, which sometimes surprises people.
Now, while it's often not serious for a healthy adult, there's a potential severity that people really need to be aware of, and that's the risk of dehydration, right?
Wow, absolutely critical. Losing fluids, salts, and minerals can escalate quickly, becoming potentially life-threatening, especially for more vulnerable groups.
Like who specifically?
Well, children, older adults, or anyone with a weakened immune system. Dehydration can unfortunately lead to organ damage, shock, or even coma in severe cases.
Wow, that really underscores why hydration is such a critical focus in treatment.
It really does. It's the first line of defense.
And it's also fascinating, isn't it, that people native to these high-risk countries or long-term expatriates, they tend to build up some resistance over time.
Yeah, that's right. Usually over maybe 2 to 5 years. Their bodies sort of learn to cope, which is why it affects them less severely than someone arriving for the first time, or why local children might get it initially, but adults less so. Acquired immunity.
Okay, so we know what it is and how common it is. Now, let's look at the gallery of culprits. What actually causes it? It's not just one thing, is it?
Definitely not. There are multiple types of organisms involved. Bacteria are probably the most common overall cause.
And within bacteria, any major players.
Yes, enterotoxigenic E. coli, or E-tech, is a big one. Some studies show it's responsible for nearly, maybe up to 1/3 of cases.
Okay.
But the sources also list other significant bacterial villains like Campylobacter, Shigella, Vibrio cholera, and Salmonella. These bacteria often work by binding to the intestinal wall and releasing toxins that cause the symptoms.
But it's not just bacteria, right?
Yeah.
The sources highlight that viruses are also pretty significant contributors.
Absolutely. And this is an area where recent research, like the Nepal study we'll talk about, is adding important nuance. Norovirus, the one famous for cruise ship outbreaks.
Yeah,
Well, it's actually the most common viral cause of traveler's diarrhea. While it accounts for maybe less than 20% of adult cases, it's responsible for a much higher percentage, around 70% in children and infants.
70%, that's huge.
It is. Other viruses involved include rotavirus, astrovirus, and adenovirus. So viruses are definitely part of the picture.
And then there are the parasites.
Yes, protozoa. Giardia lamblia is the most common protozoal cause, but others like Entamoeba histolytica and Cyclospora chiatinensis can also cause problems.
So it could be bacteria, viruses, or parasites.
Right. And here's another important insight from the sources. It's very common for people to actually be infected with multiple pathogens at the same time.
Oh, great. So a mixed bag.
Exactly. Which can make diagnosis and sometimes treatment a bit more complex.
Wow, so it's a whole microbial stew sometimes.
Yeah.
Given all these potential causes, who's more likely to get hit by this? What are the risk factors that make someone more susceptible?
Well, several factors increase vulnerability. Poor hygiene practices, of course, are a big one, directly related to that fecal-oral transmission route we talked about.
Makes sense.
But interestingly, taking certain common medications can also increase your risk.
Really? Like what medications?
Taking proton pump inhibitors, PPIs, which are often used for heartburn or acid reflux.
Yeah, lots of people take those.
Right. Or even taking antibiotics for other reasons can increase susceptibility. The sources note that PPIs reduce stomach acid, which normally acts as a barrier, helping kill swallowed pathogens.
Ah, okay. So it lowers your natural defense.
Exactly. And antibiotics can mess with your gut bacteria balance, potentially making you more vulnerable to new infections. It's an important insight for travelers who might be on these common meds.
And age plays a role, you mentioned earlier.
Yes, the extremes of age, so being very young or older, are associated with higher risk. Also, having pre-existing medical conditions,
Such as?
things like a weakened immune system, cirrhosis of the liver, diabetes, or inflammatory bowel disease, those can increase your vulnerability. The sources also list taking antacids or H2 blockers as another risk factor, again, likely related to altering that protective stomach acidity.
Okay, so if you're traveling, maybe you have some risk factors and you start feeling unwell. Moving on to the unpleasant reality, the signs and symptoms. How do you know it's specifically traveler's diarrhea and not just, something else?
The key definition provided in the sources is typically 3 or more watery, unformed stools in a 24-hour period.
Okay, 3 or more.
Or sometimes defined as a significant doubling in your normal baseline bowel frequency. This is especially relevant when it involves the abrupt passage of unformed stool while you're traveling. That's the hallmark.
That's the defining symptom. What other things often go along with it?
Well, you might feel an urgent need to defecate, experience nausea, or vomiting. And the sources note vomiting seems to be more common with norovirus infections, which is interesting. Also, significant abdominal cramping or tenderness, bloating, maybe excessive gas, and a loss of appetite. Some people might also develop a fever.
And critically, when do you need to stop self-treating or just waiting it out and actually seek immediate medical attention? What are the red flags?
This is a really vital point for travelers. You should see a doctor right away if you experience severe, intolerable pain in your abdomen. That's a big one.
Okay.
Also, if you notice bloody stools, show any symptoms of dehydration, which we talked about as potentially life-threatening things like dizziness, little or no urination, extreme thirst.
With dehydration signs.
Exactly. Also, a fever higher than 102 Fahrenheit or about 39 Celsius. And if you're persistently vomiting for more than 4 hours and just can't keep fluids down.
Got it. Those are clear warning signs that require prompt medical evaluation.
Absolutely. Don't delay if you experience those.
Right. So you have symptoms. Maybe you even have some warning signs. How is it diagnosed typically? And what's the general approach to treatment?
Diagnosis is primarily clinical, meaning a doctor relies heavily on your travel history and your symptoms. They really want to know where you've been recently.
Makes sense. Travel history is key.
Definitely. Lab tests like a stool culture, looking for ova and parasites, or sometimes blood tests might be used, but usually only if symptoms are severe, persist for a while, get worse, or if they suspect a specific, perhaps harder to treat pathogen.
And treatment. Is it always antibiotics, or what's the standard first step?
Not necessarily antibiotics first, no. It's really crucial to remember that TD is often self-limited. It usually resolves on its own in a few days for many people. So supportive care is absolutely the key foundation of treatment.
And by supportive care, you mean?
The most important thing is hydration. Replacing lost fluids and electrolytes, often using something called oral rehydration therapy or ORT.
Oral rehydration therapy. What exactly is that? Is it just like sports drinks?
Sort of, but more specific. It's a carefully balanced mix of water, salts like sodium and potassium, and sugar, usually glucose. It's crucial because plain water isn't enough to replace the vital salts and minerals you lose through diarrhea. ORT is specifically formulated to help your body absorb fluids and electrolytes efficiently, even when you're ill. You can often get packets to mix with safe water.
Got it. So hydrate first and use ORT if possible. When do medications come into the picture?
Medications might be used in more severe cases or if a bacterial cause is strongly suspected based on symptoms like maybe high fever or blood in the stool.
Okay.
Antibiotics like ciprofloxacin or azithromycin might be prescribed then. But, as we're about to discuss, resistance is a huge and growing issue, which complicates things.
Right, we'll get to that. What about over-the-counter stuff?
Sure. Options like bismuth subsalicylate The pink stuff can help reduce stool frequency and shorten the duration a bit. And anti-motility agents, like loperamide, can also help reduce the frequency of bowel movements. But they should be used cautiously, often with specific guidelines, perhaps alongside an antibiotic if bacteria are suspected. Using them alone can sometimes prolong the illness, especially with certain types of infections like Shigella or E. coli O157.
So use with caution and maybe doctor's advice.
Definitely best to check, especially if symptoms are severe.
Now, you mentioned some specific pioneering research earlier. Let's pivot to that work from the CIWEC clinic in Kathmandu, Nepal. The sources highlight their historical role, don't they?
Yes, the CIWEC clinic, working often in collaboration with AFRIMS, the Armed Forces Research Institute of Medical Sciences, has been doing incredibly important work in travel medicine for decades. Their research has been really instrumental globally.
How so?
Well, for one thing, they helped pioneer the concept of empiric self-treatment for travelers' diarrhea.
Empiric self-treatment.
Yeah, basically giving travelers going to high-risk areas a course of antibiotics beforehand, along with clear instructions on when and how to use them if they develop moderate to severe symptoms during their trip. It was quite revolutionary at the time.
Okay. And recent research from there, specifically a study from 2012-2014, gave us some really significant updates on what's causing TD in that region, right?
It absolutely did. That study confirmed, first off, that TD remains the most common illness for travelers visiting Nepal. No surprise there, perhaps. But they conducted really detailed pathogen detection.
And what did they find?
Well, they found high rates of pathogens, not just in people who were sick with diarrhea, but surprisingly also in healthy control subjects who didn't have symptoms.
Really? In healthy people, too?
Yeah, which highlights the complexity. It suggests that these pathogens are just really widespread in the environment in endemic areas, and maybe not everyone who gets exposed gets sick, or maybe some people carry them asymptomatically.
Interesting. And did they see a definite shift in the types of pathogens causing illness compared to older studies from, say, the 90s?
Absolutely, a noticeable shift.
Right.
While Campylobacter was still the most common bacterial pathogen identified.
Okay.
Norovirus emerged as the second most common pathogen overall among the cases. It was found in 17% of those with diarrhea.
Wow, so norovirus really moved up the ranks.
Exactly. This finding significantly raised the profile of viruses as a major cause of travelers' diarrhea, perhaps more so than was previously appreciated in that specific region. ETEC, rotavirus, and Shigella were also still significant contributors, of course.
And it confirmed that mixed infection idea.
Yes. Importantly, the study reinforced that having multiple infections at the same time is indeed very common in travelers with diarrhea there.
Did they find any links between symptoms and specific bugs, like the vomiting you mentioned?
They did. They found that cases where norovirus was identified were significantly more likely to report vomiting compared to cases caused by, say, Campylobacter. This helps doctors potentially differentiate likely causes based on the main symptoms the traveler is experiencing.
This really interesting data on pathogen shifts leads us to perhaps the most critical and honestly concerning challenge highlighted by this research: antimicrobial resistance, or AMR.
Yes, this is where the Nepal study delivered some truly stark and frankly worrying findings. It demonstrated a significant increase in AMR compared to earlier studies from the same clinic just a decade or two before.
Not just a small increase.
No, a major problem impacting treatment effectiveness.
And the specifics they found regarding common antibiotics? They're quite alarming, aren't they?
They really are. They found near total resistance to fluoroquinolones. That's a class of antibiotics that includes ciprofloxacin, which was, for a long time, a go-to drug for TD.
Near total resistance. What kind of numbers are we talking?
We're talking a staggering 97% resistance among Campylobacter isolates tested in that study.
97%. So Cipro is basically useless against Campylobacter there now.
Pretty much. And Shigella also showed very high resistance to fluoroquinolones at 78%. This fundamentally changes the calculus for treating bacterial TD in Nepal and likely many similar regions. Those commonly used antibiotics are now largely ineffective against some of the key bacteria.
So what about azithromycin? That's often considered the alternative or the main drug of choice now in many places, isn't it?
It is, and that's the next critical challenge highlighted by this research. The study showed emerging resistance, or at least decreased susceptibility to azithromycin, or AZM, in several key pathogens.
Oh, no. In which ones?
Well, in Campylobacter, they found 8% resistance, which was noted as a new finding at the time. In Shigella, 39% showed intermediate susceptibility, meaning it might not work as well. And in E-tech, there was 12% intermediate susceptibility and 10% outright resistance.
So even azithromycin isn't a guaranteed fix anymore.
Exactly. Higher resistance was even seen in other types of E. coli, like EAEC and EPIC. It's showing signs of becoming less reliable.
This really presents a serious challenge then. A treatment conundrum, as the researchers called it. Fluoroquinolones like Cipro often don't work for the bacteria, and azithromycin is starting to show resistance. What does this practically mean for a traveler who gets sick in Nepal or similar areas?
It means that the long relied upon fluoroquinolones are now largely useless for treating bacterial TD there, particularly if it's Campylobacter or Shigella. Azithromycin remained the recommended drug of choice based on that study's findings, but its reliability is clearly decreasing due to this emerging resistance.
So it forces a rethink.
Absolutely. It forces a reevaluation of current treatment guidelines and really underscores the urgent need to find future alternatives, or maybe even focus more heavily on non-antibiotic treatments and definitely prevention.
And the study even connected this back to that practice of self-treatment that the CIWEC clinic helped pioneer.
Yes, interestingly, they found data suggesting that travelers who had self-treated with fluoroquinolones before coming to the clinic often had bacterial isolates that were, perhaps unsurprisingly, resistant to those very drugs they'd just taken.
Which makes sense, but reinforces the problem.
Exactly. It reinforces why getting proper medical advice, especially in areas known for high AMR, is increasingly important rather than just relying on pre-packed antibiotics without knowing what bug you have or if the drug will even work.
Given this complex and evolving picture, especially with the rise of AMR, prevention sounds more important than ever. What are the absolute key strategies we should be emphasizing?
Strict hygiene is absolutely paramount. It really is the foundation of prevention.
Hand washing, I assume.
Frequent hand washing, yes, especially with soap and water. And the sources specifically make a point about norovirus here. It isn't effectively killed by alcohol-based hand gels.
Oh, that's important. So sanitizer isn't enough.
Not for everything, no. So actual soap and water washing, scrubbing properly, is really vital, especially before eating or preparing food and after using the toilet.
Okay, soap and water first. And food and water safety are the other major pillars, I guess.
Absolutely. This is where that old adage, boil it, cook it, peel it, or forget it, really comes into play.
Right. Can you break that down?
Sure. Avoid tap water, don't drink it, don't brush your teeth with it. Avoid drinks with ice made from local water. Be wary of unpeeled fruits and raw vegetables unless you know they've been thoroughly cleaned in safe water or you peel them yourself.
And street food.
Food from street vendors carries a higher risk unless you literally see it cooked piping hot right in front of you and served immediately. Generally safer to avoid it in high-risk areas.
What about drinks?
Stick to bottled water with an unbroken seal or carbonated beverages. Or you can boil water yourself, lower it to a rolling boil for at least 3 minutes at altitude, maybe 1 minute at sea level before drinking it, or using it for brushing teeth.
And swimming.
Yeah. Avoid swimming in potentially contaminated water sources like lakes or rivers near inhabited areas.
Are there any other prevention tactics people should know about? Like vaccines?
Well, there is the Dukoral vaccine. It's primarily a vaccine against cholera, but because cholera toxin is similar to the toxin produced by E-tech.
The common bacterial cause.
Right. Dukoral may offer some partial, maybe short-term cross-protection against E-tech diarrhea. It's something worth discussing with a travel health provider before your trip, depending on where you're going.
And thinking bigger picture, the sources touched on public health initiatives, especially in the Nepal context, as being part of the solution long-term.
Yes, absolutely. The significance of public health efforts like promoting sanitation and establishing open defecation-free zones in places like Nepal is really highlighted.
How does that help travelers?
By reducing environmental contamination at the source, literally, less fecal matter getting into water supplies, and the general environment, these programs decrease the risk for everyone, both locals and foreigners alike. It's a powerful reminder that the real, sustainable, long-term solution to reducing travelers' diarrhea is fundamentally about improving hygiene and sanitation standards in the host countries themselves.
So it's a global health challenge with very local and very personal impacts for travelers.
Exactly. Your health as a traveler is directly linked to the public health infrastructure of the place you're visiting.
This has been a really thorough deep dive into a condition most travelers will unfortunately encounter or at least worry about at some point.
It has. You've covered, what traveler's diarrhea is, just how incredibly common it is, the diverse cast of pathogens responsible from key bacteria like E-tech and Campylobacter to significant viruses like norovirus and various parasites.
Right. And the risk factors that make you more susceptible, the signs and symptoms to watch for,
Uh-huh.
especially those crucial warning signs requiring medical help.
hmm And the basic approach to diagnosis and treatment, really emphasizing that critical first step. Hydration, 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 preferably with ORT.
And crucially, we really dug into those eye-opening insights from the Nepal research. Seeing how the pathogen landscape is evolving, with viruses playing a bigger role than maybe we thought,
Yeah, that was a key finding.
and confronting that really serious and increasing problem of antibiotic resistance, that near total loss of ciprofloxacin effectiveness against key bugs, and the emerging challenges with azithromycin. That presents a genuine challenge for treatment going forward.
It really does. It's a major public health concern with direct implications for travelers.
Understanding these details hopefully helps you, the listener, travel smarter. It gives you the knowledge to recognize when symptoms might be serious and warrant immediate medical attention.
And allows you to appreciate the complexities involved in treating this common condition effectively, especially in a world grappling with rising AMR.
It really drives home that it's far more than just a simple case of bad food, doesn't it? It's a complex interaction of different types of pathogens, your individual health, and the broader public health conditions where you're traveling.
It certainly does. And it leaves you with something significant to consider, maybe. That vision presented in one of the sources.
Ah, yes, the idea of a future where hygiene levels improve globally to the point that travelers' diarrhea is no longer such a common concern.
Exactly. Thinking about what it would truly take to achieve that level of widespread public health improvement globally, it's a massive undertaking.
And then considering how the growing challenge of increasing antibiotic resistance complicates that hopeful picture. If our treatments become less effective, prevention becomes even more critical, but the root causes are these larger sanitation issues.
It's a powerful and maybe sobering reminder.
It really underscores that the health of travelers is fundamentally deeply linked to the health and hygiene standards of the places they visit. Something to keep in mind, perhaps, the next time you plan your next adventure.